Welcome to the Deep Dive. We take a stack of sources, dig through them, and pull out the knowledge you need, maybe with a few surprises too. Today, we're tackling reverse shoulder arthroplasty, RSA for short. Now, this isn't your standard shoulder replacement. It's quite a complex procedure, really evolving for a very specific problem. When the rotator cuff is, well, severely damaged, basically non-functional. We've got some detailed material here covering its history, the technique, outcomes, and importantly, the challenges. So our mission today is to really unpack the key insights, maybe some surprising facts from this text to get you a solid understanding of RSA.
That's a great summary. We're looking at a surgery that fundamentally redesigns the shoulder's mechanics. It has to, because the natural engine, the rotator cuff, has failed. It's a powerful solution, truly, for what used to be almost an unsolvable issue for many patients. But as our sources clearly show, it definitely comes with its own set of complexities.
Okay, let's jump right in then. This procedure, it didn't just appear fully formed, did it? It has quite a history, and, well, frankly, those early attempts back in the 70s, they weren't exactly runaway successes.
No, not really. You're talking about designs like Koebel, Kessel, the Liverpool prosthesis.
Exactly.
And the sources highlight that while they were pioneering, absolutely, they largely failed to consistently relieve pain or restore function, especially in rotator cuff arthropathy.
Why was that? What was the main sticking point?
Well, the core issue was they tried too hard to copy the natural shoulder anatomy, a convex glenoid, the socket part, and a concave humerus, the ball part. But that anatomical design relies entirely on having a working rotator cuff to keep everything centered and stable.
Which is precisely what's missing in these patients, right? So trying to rebuild a normal joint when those crucial stabilizing muscles are shot just off.
It just didn't work.
Exactly.
The humeral head, the ball, would just sort of drift upwards because nothing was holding it down. And this led to instability and, critically, loosening of the glenoid component, the part fixed to the shoulder blade. It just couldn't handle the abnormal forces.
Okay. So the big shift, the kind of fundamental rethink, had to be moving away from just copying anatomy and towards creating mechanics that could actually compensate for that missing rotator cuff.
Absolutely. And this is where, the story gets really interesting. The revolutionary step, and the sources really emphasize this, came from Paul Gremmon in 1985. He essentially flipped the script, anatomically speaking. A large hemisphere on the glenoid side of the socket, and a small cup on the humerus side of the ball.
So wait, the socket becomes the ball and the ball becomes the socket. Is that basically it?
In essence, yes,
Yeah.
a reversal. And his design had two major innovations that were, well, game changers, according to our material here. First, he medialized the center of rotation. He moved it inwards toward the body's midline and fixed it firmly on the glenoid side.
Medialized. Okay, so moving the pivot point.
Exactly. And doing that significantly reduced the torque, the twisting forces, on that glenoid component. That directly addressed the big loosening issue from earlier designs, and it made the whole thing much more stable.
Right, less torque means less likely to wiggle loose. Makes sense. What was the second big idea?
The second innovation was effectively lowering the humerus, the arm bone, relative to the glenoid. This increased the tension on the deltoid muscle, that big muscle capping your shoulder, and dramatically improved its leverage, its mechanical advantage.
So it makes the deltoid work harder, or rather, more effectively.
Precisely. Suddenly, the deltoid, which isn't really designed for that primary lifting role, could function much better as an abductor. It could lift the arm, even without the rotator cuff doing its job. And this Grammont design, it was truly foundational. Almost every system that came after built on those principles.
That really does sound like a genuine biomechanical breakthrough, but I assume design didn't just stop in 1985. There's been refinement since then.
Oh, a huge amount, yes. Later designs, you see names like Delta Third, Duocentric Expert, Universal Aero, SMR. They all built on Grammont's core ideas, but introduced modularity and really aimed to, fine-tune outcomes and reduce those complications.
How so? What were they tweaking?
Well, for instance, they worked on improving the range of rotation. Some designs placed the glenosphere, that ball part, a bit less medially, less inwards than Grammont's original Delta design, trying to help with that.
And preserving the patient's own bone stock, that sounds like it would be a constant goal.
Critically important, yes. You see features like modular pegs in some systems, like the SMR axioma or metal back glenoid components. These give surgeons more options to manage bone loss and offer more flexibility during the operation. They also made it easier sometimes to convert from a previous failed implant.
And you mentioned stems.
Right. Another major development was the introduction of shorter humeral stems. The sources point out this was specifically to try and avoid complications tied to those traditional long stems, things like fractures around the implant, or the stem puncturing the bone shaft, or even the stem loosening over time.
Okay, so designs have clearly evolved. They're more stable, more modular, aiming for fewer complications.
They have, significantly.
Yeah.
But, and this is a really key insight from the sources, even with over 20 years of follow-up on some of these, let's call them early modern designs, issues like glenoid loosening and a specific complication called scapular notching, they're still present.
Still, even now.
Yes, improved, definitely, but not completely eliminated. It shows how challenging this joint is.
Okay, let's switch gears slightly. Why would someone actually need this procedure? The main reason, the primary indication, is often cuff tear arthropathy or CTA. What exactly is that?
Right. CTA is a pretty specific and severe condition. You've got glenohumeral osteoarthritis or arthritis in the main shoulder joint, but it's happening alongside a massive irreparable tear of the rotator cuff tendons and significant muscle dysfunction. The sources describe it as a spectrum. It can start with the humeral head just migrating upwards because the cuff isn't holding it down, leading to progressive cartilage damage. And it can go all the way to, well, significant erosion and even collapse of the humeral head and the glenoid socket.
But how does a torn rotator cuff cause osteoarthritis? You usually think of arthritis as just wear and tear over many years.
That's where the mechanical theory comes in, and the sources seem to lean heavily on this explanation. Without the rotator cuff, especially the supraspinatus muscle, doing his job of keeping the humeral head centered in the socket, the pull of the big deltoid muscle causes the head to slide upwards, and it starts rubbing abnormally against the top part of the glenoid socket and the acromion bone above it.
Ah, so it's grinding where it shouldn't be grinding?
Exactly. These abnormal sort of focused mechanical forces essentially grind away the joint cartilage and eventually the bone itself. The sources mention studies suggesting these mechanical factors are really the primary driver, maybe even more so than other theories about changes in joint fluid flow or nutrition.
So it's less about general wear and tear and more about the mechanics being fundamentally broken, leading to targeted destruction.
That's a good way to put it. The missing cuff leads to a mechanical failure pattern that destroys the joint's surface over time.
And for the patient living with this, what does it feel like? What are the telltale signs of CTA?
Well, pain is usually the first and foremost symptom. Often it's been there a long time, getting progressively worse. Patients often say it's worse at night or with activity. The pain is typically felt on the side or maybe the back of the shoulder, sometimes radiating down the arm. It can range from, a nagging ache to something severely affecting quality of life.
But it's not just pain, is it? The tear arthropathy part implies movement problems.
Definitely. A defining feature is the progressive loss of motion, particularly active motion, trying to lift the arm themselves.
Leading to that term you sometimes hear, pseudoparalysis.
Exactly, the inability to actively lift the arm away from the side. You can often actually see the humeral head migrating upwards when the patient attempts to raise their arm, and loss of external rotation, turning the arm outwards, is also a very common and significant limitation.
What else might you see or might the patient notice?
Well, they might have chronic swelling in the joint, maybe episodes where it gets particularly painful and puffy. And you almost always see visible muscle atrophy, muscle wasting, particularly in the infraspinatus and supraspinatus areas on the back of the shoulder blade.
And if a doctor examines them?
You might feel or even hear crepitus, that sort of grating or grinding sensation with movement. The shoulder's profile can look abnormal, kind of deformed, because the humeral head has shifted upwards. And those specific physical tests for the rotator cuff, things like the Job test, Volcan test, Pat Tessos, various lag signs, they'll typically be positive, showing weakness or an inability to hold the arm against resistance in certain positions.
So, if a patient comes in with these kinds of symptoms, how do clinicians confirm it's CTA and figure out how bad it is? What imaging gets used?
Standard radiographs, so just plain x-rays, are always the first step. They're easy to get, low cost, and they show quite a lot.
Like what specifically?
Clinicians look at the acromiohumeral distance, that space between the top of the arm bone and the acromion bone above it. In CTA, this space is narrowed or even gone completely because of that upward migration. X-rays also reveal changes in the bone shape, joint space narrowing indicating cartilage loss. The sources mention specific classification systems based on X-rays, like Hamada or Vysotsky-Seebauer. These systems grade the severity based on things like that acromiohumeral interval, how much the head is moved up, signs of instability, and the pattern of bone erosion.
Okay, X-rays give the overview. What about ultrasound?
Ultrasound is really good for looking at soft tissues like the rotator cuff tendons themselves in high resolution. It's excellent for confirming there's a massive tear. It can also give some insight into that acromion humeral interval and show the condition of the muscles looking for atrophy or fatty infiltration where muscle turns to fat. A big plus for ultrasound is its dynamic capability. You can watch how structures move in real time.
And then the big guns, MRI and CT scans.
Right. MRI is usually the go-to for detailed evaluation of the soft tissues, especially the quality of the rotator cuff muscles. It's very good at grading that fatty infiltration. CT scans, on the other hand, are superior for looking at the bone. They're crucial for really understanding the extent of bone loss, particularly on the glenoid side, the socket. And CT allows for creating 3D reconstructions, which are incredibly helpful for planning the surgery.
You mentioned fatty infiltration grading.
Yes, the Goutallier-Fuchs classification. It's based on CT or MRI images and grades, how much fat has infiltrated the muscles from grade 0, which is normal, up to grade 4, which is mostly fat. The sources highlight this grading is important because it gives an idea of the muscle's potential function after surgery. More fat means less potential.
And CT helps with the glenoid side, too.
Definitely. Assessing the glenoid version, its tilt and its overall shape or morphology is key. The Walsh classification is often used here, helping surgeons understand how much bone is missing and where, which is vital for deciding where and how to place that base plate implant.
So while CTA is the most common reason for RSA, our sources detail that it's also used in other pretty complex scenarios. It's not just for CTA.
That's right. RSA becomes the choice when standard shoulder replacements likely won't work, often because of major issues with the rotator cuff or severe bone damage. One major indication is acute proximal humeral fractures, bad breaks at the top of the arm bone, especially complex 3 or 4-part fractures in older patients who might already have poor bone quality or existing cuff problems.
Why RSA for a fracture?
Because in those cases, getting the broken pieces, the tuberosities where the cuff attaches, to heal reliably and getting the rotator cuff to function again is often, well, unpredictable. RSA kind of bypasses that dependency. It relies more on the deltoid, which we talked about, so it tends to offer better pain relief and more consistent functional results compared to other options like hemiarthroplasty, just replacing the ball in this elderly population.
So when a fracture is really shattered or the bone is weak, RSA might be a more predictable path forward.
Exactly. It avoids relying on healing that might not happen well. It's also used for what they call fracture séquelae problems that arise after a fracture hasn't healed correctly. Things like non-unions, where the bone doesn't mend, or malunions, where it mends in a bad position, or post-traumatic arthritis combined with cuff failure.
So fixing problems from previous fractures.
Right. In these really complex cases, RSA can be a better option than trying to redo a hemiarthroplasty or an anatomic total shoulder replacement. But the sources are very clear here. These are difficult surgeries. They carry significant complication risks, dislocation, infection, nerve injury, even new fractures during the surgery, previous operations, existing bone loss, stiff scarred tissues. It all makes them very challenging.
It really sounds like RSA is the go-to tool when surgeons are facing situations where the normal anatomy is significantly distorted or damaged beyond simple repair.
Precisely. And this logic extends to even more severe cases, like tumors involving the proximal humerus, the top of the arm bone, that require extensive removal of bone and soft tissue. Reconstructing stability and function after such large resections is a major hurdle. RSA in this context can help provide stability and pain control, aiming to restore enough arm mobility so the patient can at least use their elbow and hand effectively. Interestingly, while instability rates after RSA for tumors can be higher than for primary RSA for CTA, the sources suggest it might offer better stability than other reconstructions, like hemiarthroplasty in these specific oncological scenarios.
And the last big category mentioned is failed previous shoulder replacements.
Yes, absolutely. Revising a failed hemiarthroplasty or a failed anatomic total shoulder arthroplasty is a frequent reason for needing an RSA. These are inherently complex cases because you're dealing with scar tissue from the previous surgery, potential bone loss where the old implants were, and always the underlying concern about a possible low-grade infection from the prior procedure. And the sources generally indicate that revision RSA, doing it as a second or third operation, typically results in somewhat lower functional outcomes and higher complication rates compared to doing a primary RSA for something like CTA. You're starting from a more difficult baseline.
Okay, that covers the why. Let's dive into the surgery itself a bit more. The sources touch on biomechanical considerations and some key technical insights. What stands out there?
Well, they mentioned the common surgical approaches, like the delta pectoral approach between the chest and shoulder muscles. That's pretty standard. But The really critical technical points revolve around positioning the implant components. Getting the new mechanics just right is everything for RSA.
Okay, like the humeral component, the part in the arm bone.
Yes. The angle of that component relative to the shaft of the bone, called the inclination angle, is key. The sources note that while a 155-degree angle is very common, it's also associated with a higher chance of scapular notching. Some surgeons prefer other angles, like 135 degrees, potentially for that reason. Also, the rotation of the humeral implant, its version, is crucial.
Version? You mean how much it's twisted?
Exactly. The sources suggest around 20 to 40 degrees of retroversion twisted slightly backwards is generally needed to allow for a good functional range of motion. Putting it in neutral or even slight anteversion, twisted forwards, increases the risk of the implant hitting the back of the scapula, causing posterior notching. Surgeons often use the alignment of the forearm as a guide during surgery to set this rotation.
So getting that angle and rotation just right is all about maximizing movement while minimizing parts bumping into each other.
That's the goal, creating smooth, stable motion within the new mechanical constraints. Now, on the glenoid side, the socket side, placing the base plate, the metal plate to the new ball, the glenosphere, attaches to as inferiorly as possible on the glenoid face is really emphasized.
Inferiorly, meaning lower down, towards the armpit side.
Yes, exactly.
Yeah.
Placing it lower down, but importantly, not letting it hang over the bottom edge of the bone. This is done specifically to minimize that scapular notching we mentioned. And it also helps improve the patient's ability to bring their arm down towards their body, adduction. There's still some discussion, the sources note, about whether adding a slight inferior tilt to the base plate helps further. But biomechanical studies confirm that both the humeral implant angles and the precise placement of the glenosphere significantly impact outcomes and the risk of complications.
And how that base plate is fixed to the shoulder blade bone must be absolutely vital for it to last long term.
Paramount, yeah. Glenoid baseplate fixation is critical. It relies on achieving solid stability right away, allowing the bone to eventually grow into the implant surface that's osseous integration. Success here depends heavily on the patient's bone quality, the specific shape of their scapula, and of course the type and placement of the screws used to hold it. The sources mention that using locking screws generally provides better initial stability. They also add a note of caution about the risk of damaging nearby nerves or tissues when putting those screws in. The suprascapular nerve and artery and the subscapularis muscle tendon are structures surgeons need to be mindful of.
Any quick notes on anesthesia from the sources? Anything interesting there?
They do mention that regional nerve blocks, like interscalene or supraclavicular blocks, are very commonly used for anesthesia and post-op pain control. A key point highlighted is that using ultrasound guidance for these blocks has really improved their safety and feasibility. Surgeons can see exactly where the needle and anesthetic are going. Although, like any procedure, they still carry potential risks, usually temporary nerve issues, but rarely more severe complications can occur.
All right, we've covered the technique, the positioning, but it really seems, despite all the advancements, that complications remain a significant challenge with RSA. The sources dedicate quite a bit of space to this.
They do, and it's a crucial aspect to understand. Despite the improved designs and techniques, RSA still carries a relatively high complication rate. You have to remember it's often used in patients who already have complex problems and maybe other health issues. The Zumstein study, which is cited in the material, reported a global complication rate of around 24%, with about 10% needing revision surgery. Though it's fair to say other studies report different figures, it depends on the patient group and exactly how complication is defined.
24% is quite high for surgery. What are some of the most significant complications that surgeons and patients worry about?
Well, infection is certainly one of the most severe. It can be devastating. The sources discuss how the timing of diagnosis, early, delayed, or late after surgery, can influence the type of bacteria found. Propionibacterium acnes, now called Cutibacterium acnes, is mentioned as a common culprit, particularly in delayed or late infections, because it's a slower-growing organism.
How do they diagnose it definitively?
The gold standard, as emphasized in the text, involves taking multiple deep tissue biopsies during surgery and sending them for culture. It's stressed that holding these cultures for an extended period, like 14 days, is important specifically to catch slow growers like P. acnes. And ideally, antibiotics should be withheld before taking these samples if it's safe to avoid masking an infection.
And treating these infections sounds like a major undertaking.
It absolutely is. The treatment strategy really depends on the specific situation. For very early infections, if the implant seems stable, sometimes surgeons attempt a debridement, a washout, and implant retention. maybe exchanging the mobile plastic parts. But for most established infections, the two-stage exchange is considered the gold standard. This means removing all the implant components, doing a very thorough cleaning and debridement, placing a temporary spacer usually loaded with antibiotics, letting things quieten down for weeks or months, and then, only if the infection seems cleared, going back for a second surgery to reimplant a new prosthesis. Other options exist, like removing the implant permanently or just managing with long-term antibiotics, but the two-stage is often preferred for cure. The sources really stress that managing these infections requires a team approach involving infectious disease specialists, and that prevention, meticulous sterile technique, prophylactic antibiotics, careful skin prep is absolutely paramount.
Okay, infection sounds tough. We also talked about scapular notching earlier, related to implant design. It's listed as a common complication too, right?
It is, yes. Scapular notching is that finding on an X-ray, where you see erosion at the bottom edge of the scapular neck. It's caused by the humeral cup part of the implant bumping against it during arm movements, particularly adduction, bringing the arm down. And as we discussed, it's definitely linked to the implant design, like the neck shaft angle and how the implant is positioned, particularly the glenosphere offset and how inferiorly it's placed. Techniques like placing the glenosphere as low as possible or using special augmented components to effectively lateralize the center of rotation are aimed at reducing it.
But here's the interesting bit you mentioned.
Right. The surprising insight from the sources is that there's still an ongoing debate about how strongly this radiographic notching actually correlates with poorer clinical results for the patient in the long run. Does seeing notching automatically mean the patient is doing worse or will have problems later?
That is surprising. You just assume seeing bone getting worn away is bad news?
Intuitively, yes, but the evidence, according to these sources, isn't completely clear-cut yet. It highlights that we're still learning about the long-term implications of some of these common findings. Longer-term studies are definitely needed.
Okay. What else is on the complication list?
Instability or dislocation is another significant one. It's particularly a risk in those more complex cases, like revisions or after severe trauma.
What makes instability more likely in RSA?
Several factors mentioned include insufficient tension in the surrounding soft tissues or damage to key stabilizers like the subscapularis muscle at the front. Significant bone loss, either on the humerus or glenoid side, can contribute. Malposition of the implant components themselves. And sometimes just poor muscle control or function after the surgery. The sources even mentioned there's some controversy in the literature about whether formally repairing the subscapularis muscle during RSA actually helps prevent instability or not, especially with the more medialized designs.
Interesting debate there too. What about fractures?
Periprosthetic fractures, meaning fractures occurring around the implant components, are another challenge.
Do these happen more often during the surgery itself or afterwards?
The sources note that intraoperative fractures happening during the surgery are actually more frequent, particularly during revision surgery, where removing the old, well-fixed implants can be quite difficult and put stress on the bone. These fractures can occur around the stem in the humerus or sometimes further down the shaft. Treatment depends on where the fracture is and how stable things are. It might involve using wires, plates, or sometimes needing to use a longer revision stem to bypass the fracture. While healing rates are generally reported as good, these fractures are definitely associated with other complications and can lead to potentially less optimal functional results down the line.
Nerve injury is also mentioned.
Yes, peripheral nerve lesions. The axillary nerve, which supplies the deltoid muscle, is the one most commonly discussed.
That sounds serious given how important the deltoid is for RSA function.
It does, but the sources note that while these nerve issues are relatively common, they're often temporary or even subclinical, meaning the patient might have some electrical sign of nerve irritation but not actually notice any weakness. Anatomical studies cited suggest the axillary nerve usually runs a safe distance from the glenosphere itself, but it can be vulnerable near the back of the humerus or potentially stretched if the arm is significantly lengthened during the surgery by the implant.
Okay. And finally, loosening of the implants themselves. Still a concern.
Still a concern, yes.
Yeah.
We talked about how glenoid loosening was a major issue with the very early designs.
Right, the pre-Grammont era.
Exactly. And while much improved with modern baseplate designs and fixation techniques like locking screws, it still occurs and needs to be monitored. Humeral component loosening is also watched for, using specific radiographic criteria in follow-up studies. That stability of the glenoid baseplate really is crucial, and it depends so much on the patient's bone quality, how well the pegs or keel anchor into the bone, and the number, type, and placement of those fixation screws. Other less common things are mentioned too, like hematoma formation, collections of blood, and complications related to the acromion bone, the bone overlying the shoulder joint.
Wow, okay. That's quite a comprehensive list of potential pitfalls. It really does underscore the complexity of this surgery.
It absolutely does. And it brings us really nicely to another crucial point that the sources emphasize repeatedly: patient factors. Beyond the implant and the surgical technique, the patient's own characteristics significantly influence both the potential outcomes and the risk of these complications.
So it's not just if you do the surgery or how you do it, but very much who you do it on.
Precisely. Age is one factor, for instance. While RSA is often thought of for older patients, the sources note its use is increasing in younger individuals, say under 55 or 60. But they stress we simply lack good long-term data on how well these implants survive in that younger, potentially more active group. Conversely, in the very elderly, while maybe their functional demands are lower, putting less stress on the implant, their age inherently increases the risks of general medical complications around the time of surgery, like blood clots or heart issues.
And comorbidities, the patient's other existing health conditions, seem absolutely critical to consider.
Paramount, yeah. The sources mention tools like the Charlson Comorbidity Index or the ASA Physical Status Classification, which surgeons use routinely to gauge a patient's overall medical risk profile before even considering surgery. And the text lists a whole raft of specific conditions identified as increasing surgical risk for RSA. Things like previous heart attacks, heart failure, peripheral vascular disease, history of stroke, dementia, chronic lung disease, connective tissue disorders like rheumatoid arthritis, liver or kidney disease, diabetes, especially if it's poorly controlled or caused end-organ damage, hemiplegia, any active cancer or history of metastatic cancer, AIDS.
That's a very long list.
It is. And even things like recent dental work can be a concern due to the risk of bacteria entering the bloodstream and seeding an infection around the new joint. Hepatitis C is also mentioned as an infectious risk factor.
So a very thorough medical workup is needed.
Absolutely. And specific conditions carry specific risks. Diabetes, for instance, is linked in some studies to poor early functional outcomes after RSA. Rheumatoid arthritis is known to increase infection risk in joint replacements generally. Poor nutrition, sometimes indicated by low serum albumin levels, is linked to increased need for blood transfusions. Certain neurological conditions like Parkinson's might potentially increase the risk of instability or loosening. Malignant tumors, as expected, significantly increase the overall complication risk. The sources strongly emphasize that all these comorbidities must be carefully weighed up when planning treatment. For some patients with very high medical risks, surgery might simply not be the right or safest option.
And presumably the quality of the bone itself is essential for the implants to grip onto.
Absolutely vital. You need good bone stock for stable fixation, especially for that glenoid base plate. This is particularly relevant in patients with osteoporosis or other conditions that cause bone thinning or loss. This is another area where that detailed preoperative imaging like CT scans and 3D planning becomes so important. According to the sources, they help surgeons assess the bone stock accurately and plan ahead, maybe deciding if bone grafting will be needed to build up deficient areas before placing the implant.
Okay, so patient selection is key. Finally, let's touch on managing patient expectations. What can patients realistically expect after undergoing an RSA? Is it a return to a normal shoulder?
This is such a critical part of the whole process, and the sources highlight it well. While pain relief after RSA is often excellent, really dramatic in many cases, and functional improvement is usually significant, the sources emphasize that recovery varies, and it is generally not a return to a completely normal arm, especially compared to someone who never had a shoulder problem.
What kind of limitations might remain?
There can often be some lasting limitations, particularly in external rotation, turning the arm outwards. Sometimes patients might notice limitations in, say, the speed or fluency of their arm movements or maybe reaching behind their back. Fine motor control for certain tasks might not be fully restored. So patients really need to have realistic expectations set before the surgery about these potential residual limitations, especially when comparing it to a healthy, uninjured shoulder.
How do they measure success then, if it's not always normal?
Well, standard outcome scores are used, like the CONSTANT score, which measures pain, function, motion, and strength. But the sources make an interesting point that these scores might not fully capture some of the more subtle functional limitations patients experience in their daily lives. They suggest that maybe activity-focused questionnaires, like the DSH score, disabilities of the arm, shoulder, and hand, might provide a more complete picture of what the patient can actually do in their day-to-day activities. And importantly, rehabilitation after RSA is different from rehab after other types of shoulder surgery. It needs to be tailored to the specific mechanics of the reverse implant and aligned with those realistic functional expectations.
This deep dive has really shown a light on the whole journey of reverse shoulder arthroplasty, hasn't it? From those, frankly, difficult early attempts through the revolutionary Grammet design and on to the continuous evolution we see today aimed at refining outcomes, it's clearly a very powerful, often life-changing procedure for some incredibly complex shoulder problems, especially when that rotator cuff is effectively gone.
It absolutely is. It provides solutions, good solutions, where maybe only 30 or 40 years ago, there really weren't any effective surgical options for these patients. It's incredibly effective for the right indications. But as the sources meticulously detail, and as we've discussed, it is also a technically demanding procedure. It's complex surgery, and it's associated with notable risks and a not insignificant rate of complications.
And success, it seems, really hinges on a whole constellation of factors, doesn't it? It's not just the surgery itself. It's selecting the right patient in the first place, deeply understanding their specific pathology, appreciating the unique biomechanics of the reverse implant.
Executing that meticulous surgical technique, being prepared to address issues like bone loss, carefully managing those crucial comorbidities we talked about.
And as you just highlighted so well, ensuring patients have genuinely realistic expectations about what their functional recovery is likely to look like. It's not always about getting back to perfect.
Absolutely. And the sources make it clear that the work isn't finished. Design and technique are still evolving, constantly aiming to minimize those complications, maybe improve longevity, perhaps even carefully expand its use to new patient groups where appropriate. But it remains a procedure that really underscores the inherent complexity surgeons face when trying to reconstruct and restore function to such a sophisticated and demanding joint like the shoulder.
A truly complex solution for a complex problem indeed. Thank you so much for guiding us through all that detail today.
My pleasure. It's a fascinating area.
And if you, listening, found this exploration of reverse shoulder arthroplasty insightful, please do take just a moment to rate and share this deep dive wherever you get your podcasts. It genuinely helps other curious minds find the show.